Good afternoon, everybody, and welcome to the ICD10 Coding Tips for Success presentation with Liz Barlow and Kathy Atkins. Everyone is on mute. Everyone's automatically on mute. We'd ask everyone stays that way. There's no need to touch mute. At this time, I'd like to introduce Liz Barlow. Liz, the floor is yours.
Hey, Ted. Thank you for that. Yeah, everybody, a great turnout. I'm so excited to have you guys join us today. And I'm happy to kick off a series of educational webinars and other educational handouts that we're calling PDPM, Prepare, Plan, and Perform. And so over the next, 9 to 12 months, we're going to continue to partner with you along the way of this very exciting, I think, transition to a new payment. So we thought we would do a few things. One is, in what you can anticipate, we hope to have at least some monthly webinars. Some will be very short. It may be, just a 15, 20-minute kind of snippet, as I call them. Others may be certainly more detailed. One of the more detailed courses or webinars that we hope you all will join us in will probably be first quarter, and it will probably go into much more detail on just some ICD-10 coding basics. That's just an example of one of the many webinars that we're going to be hosting for you all. Be sure to look for your Partnership First email blast. That will also have other information on there as things continue to be rolled out and we get updated on what CMS is instructing us on in regards to PDPM. I think we've got a very exciting year ahead of us, and we all have a lot to learn. So today, as you all know, is going to be one of the shorter webinars, but what we want to do is really to get you all start talking about ICD-10. And I'm going to go through a few of the areas on PDPM on how the diagnosis is really going to impact payment. And then Kathy Atkins, who is the Director of Quality with us, is going to go into just a little bit more detail about what that looks like on the MDS. And then really start preparing you by asking questions about, processes and ways that you all can start some discussions in your facility about how to start getting prepared. We certainly don't have all the answers right now, but I think that as we go through the next, 9, 10 months and starting to look at our current processes and maybe ways we can improve will help us out, as we do make that transition from September to October 1 of next year. As you all know, the PDPM will be implemented on October 1st. So again, we've got a good 9, 10 months to get ready for that. And as we go through it, just a visual, we know right now that the payment is certainly going to look much different than what it does today under PPS. And CMS is focusing in on the needs of the patient versus, the therapy minute-driven, certainly. So this is an example of what CMS shared on one of their slides. We have payments from different components for PDPM. We know there's PT, OT, there's speech component, there is nursing, and then there's a non-therapy ancillary. Those all have case mix indices attached to them. And then there is a non-case mix that doesn't change. That is your date. That's going to be similar to a daily rate. But you can see some of the bubbles on this are bigger. And they're showing us that to say that, depending on what is going on with the patient, your CMI may be a little bit higher in that area than in some of the other areas. So again, it's much more driven by what is happening with the patient, comorbidities, diagnoses, and functional level, for example. Here is a quick PDPM payment snapshot. Again, I just talked about the 6 different components. We have, the PT, OT speech, non-therapy ancillary, nursing, and a non-case mix. And I apologize for the background noise, but I'm going to keep talking. So each of those also has a CMI attached to them. And as we talk through the next few slides, you're going to see how the impact of diagnosis can also impact your daily rate. So, for example, we get a base rate in each of these areas. The CMI fluctuates depending on what's going on and the resources and the qualifications that CMS has outlined that impact that area. So, and we're going to talk about that again. Kathy's going to talk about that a little bit more. I'm going to pause for just a minute because we're hearing a lot of background noise. Ted, I don't know if you're able to find them or not.
I think I just did.
Okay, perfect. Thanks so much. So when we look at diagnosis specifically, it really impacts these 4 areas more than others of the PDPM. So the PT CMI is impacted by the primary reason for SNF care, as is OT. Speech also has a primary reason for SNF care, and those are based on the admission diagnosis. Kathy's getting ready to go into a little bit more information on that and what that looks like, which is much different than today. The MDS is adding a new section called the I0020B, and that's actually a new section that was just released a couple of weeks ago. All of the information that we've heard to this point has been about I8000. And CMS has a new PDPM website, and in some of the information on there, they updated that there's going to be a section called I0020B, and the question on there is going to be, what is the diagnosis for primary reason for admission to the SNF? So that directly impacts the diagnosis and the mapping for PT and OT. It also impacts speech. Nursing, it impacts a little bit more indirectly. The nursing CMI for PDPM is impacted very similarly to the current regs. So while that section, I0020B, may not have the direct impact like it does for PT, OT, and speech, certainly the diagnosis that you check off and comorbidities in different sections of the MDS are going to have an impact on that CMI. So, Kathy, I am going to pass it on to you and let you talk a little bit more about how that primary diagnosis in that section of the MDS is going to, how that looks on the MDS and some things the facilities can do to prepare for that.
We know that patients are going to be classified into one of the 10 clinical categories based off what the primary diagnosis for the SNF. So we know that I have to be really good at diagnosis is, and we know that the ICD10 code is going to be coded in the I8020B that Liz was just talking about. So this is just that snapshot of what those PDPM clinical categories are going to look like. We know that we're going to be looking at joint replacements, non-surgical.
Jeremy would probably eat them.
Phases, medical management, pulmonary, cardiovascular, acute neurologic, and non-orthopedic. 10 primary clinical categories. Next slide, Liz. So some of the MDS changes that we know, effective 10/1/19, we know that the MDSs are going to be limited to the 5-day assessment, and then you'll have an interim payment assessment. Yeah. Those are going to be optional, and those are only going to be used when a clinical change requires that the new PPS assessment is done. And then you have your PPS discharge assessment. So this kind of gives a little snapshot of when you're going to do those. So that first 5-day assessment is going to be done day 1 through 8, and those interim are not going to be done unless something major clinically goes on, and maybe you've got to add additional diagnoses. So, and then you're going to do the discharge at the end. So let's go to the next slide. So like Liz talked about, we know there's some new MDS items. The Section I classifies that patient into that PDPM clinical category. So they did add the I0020B. That's the main reason that the person is admitted to the SNF. So we got to make sure that those ICD10 that we're capturing and the main reason that they're admitted is going to be that primary reason in there. We do know from all the research that we've been doing, all the reading, that if they were admitted to the hospital and something gets resolved, that's not going to be your ICD10 that you're going to use for your reason for admission to the SNF. So you got to be really good at at looking at those ICD-10s and matching that ICD-10 for that primary reason. That's going to be key, that you understand what that primary reason is, because that's going to kind of set your payment. And then we also know that there's a Section J now, J2100 through J5000. This is major surgical procedures during an inpatient hospital stay that preceded the admission to the skilled nursing facility. These are going to be used in conjunction with your diagnosis codes to capture that and I'm not saying this right, the I0020B, to classify into the PTOT case mix classification groups. So we know these are two new sections that they've added to the MDS. Next slide. We kind of give you just a snapshot so you can see what the Section J looks like. And these are the surgical procedures and the categories that you're going to be using. And you can see it's a lot of what we get now for our skilled nursing facility patients, everything from just a recent surgery to joint replacements to spine surgery to other major surgeries. So we just kind of wanted you to have a snapshot so you could look at what they're putting in there for this J100 to the J5000 area. Next slide. So there are 5 things that we've kind of come up with that we feel like that if you do now, it's going to help you get prepared for what we know is going to come up. So one of the things that you really need to be looking at is you need to kind of audit or review the ICD-10s that you've been using during the past year because you really want to look at those diagnoses and you want to look to see, are you seeing any kind of trends with admissions that you've been getting? So what are you using now as the main reason for that admission to the skilled nursing facility? And are you capturing surgical information when a patient has been in the hospital for surgery? Are you using unspecified ICD-10s? I would really caution everybody about using those unspecified codes. You really should only use an unspecified code if the doctor has not assigned a more specific code. And if it is unspecified, go to the doctor and see if they'll give you a more specific ICD-10. And then are you using Z codes? We know that Z codes are factors that influence health conditions. Z codes are not standalone codes. They're not a standalone medical diagnosis, and they're not a standalone therapy diagnosis. They're not for treatment either. They have to have a condition that goes along with why the Z code is there. I think sometimes people are still looking for that V code that we used to have in ICD-9. There's no direct mapping over to ICD-10 for that. So the Z codes did not replace that. So I'd be kind of cautious about using them. There is a place for them, but you really need to code something else with it. So, and then are you capturing all the comorbidities of the patient? Because we do know that the non-therapy ancillary, you need to be able to capture all additional diagnoses and comorbidities, especially when they're factoring into the speech-language pathology comorbidities. It does classify them into the speech-language component and then the non-therapy ancillary comorbidity score. Next slide. So one of the things you might want to think about is who's going to be responsible for your coding beginning in October of next year. Who's doing it now? Is it an MDS person doing it? Is a BOM doing it? Is someone in medical records doing it? Is there an admission nurse that's doing it? And then you need to look at their skill set and their comfort level for coding. I think sometimes people get thrown into it and they code and they're not really understanding it. So, and look at who you think is going to be doing it in the future and look and assess, have they had any kind of formal training? If they've not, you might want to consider getting them into an ICD-10 class. And how long has it been since they've taken any training on coding? And do they need more training or education? I'm going through coding classes now for certification, and I can tell you in the first 3 chapters of this course that I'm taking, I learned more than I have ever known about coding, and the big key is how to use that book. And I would recommend if you don't have a book that you purchase a book for this next year because you do need that book so you can read all the notes and exclusions that are in there. Next slide, Liz. You also need to look at your nursing documentation and take a good look and make sure that nursing is capturing everything that's going on with that patient, because a lot of times patients get admitted to the facility. Nursing is the one that's doing the intake assessment, They're the one that's getting the information from the hospital. So we want to make sure they're really good at capturing all the information that they need and look at how they're documenting the current admissions to the facility. Are they capturing all the ICD-10s and the comorbidities that the patient have? Because we know that those are going to be key for how PDPM is going to run. And does their documentation capture all the clinical needs and complexities of the patient? And then you also might want to look at your restorative nursing program, because there is a restorative nursing component in there. So you might need to take a good hard look at that too and make sure that you're capturing all the restorative nursing needs of the patient. Next slide. This is key. What is your referral source for how you're getting your information now? Are you getting timely discharge information from the referral sources for your admissions? If it's a local hospital, are you getting those discharge summaries that have all the information in it? Or is it coming 3 or 4 days after someone's admitted? Because it's going to be key that you get all that information about that hospitalization right away so you'll be able to do your 5-day assessment. And are you getting all the medical complexities of the patient on the admission? Because it's key that you know what that patient's past medical history is, because it's going to be important that we do capture all those comorbidities and the complexities that they have. And you need to kind of look to see what do you need to do now to build that strong rapport to make sure that you're getting that discharge information timely, because you really need that accurate coding information to prepare for what's happening with PDPM in October of next year. The last thing that we were looking at is the triple check process. So what is the triple check process that you have right now with rehabilitation? Do you have a triple check process? Is your managers in rehab comparing the diagnoses that we're using in rehab with the facility? Is it being done with the MDS? Is it being done in a Medicare meeting? Is it just the MDS and the manager sitting down and go over it, or do you not have anything in place right now? You really need to look at how often you're doing that, because if you're in a building with a lot of moving parts and a lot of admissions, that's something that probably needs to be done on a daily basis. Are you doing it at all? Are you doing it daily, weekly, monthly? And then how accurate do you think that therapists are at capturing the clinical needs of the patients with their treatment diagnoses? We've been doing a lot of training, and we'll probably do more training in the future, because we want to make sure that our therapists are also capturing the comorbidities, because that's the way we train them now when they do a comprehensive plan of care, to capture all the comorbidities that the patient have that we know are going to have an impact or impede rehab. And that's going to be key, too, for the future with PDPM. We did put some resource information in here. CMS has the new website for PDPM. I went in this morning and was looking at it, and there's a brand new document on there on frequently asked questions. So we've got the link here in the PowerPoint. There are 3 files in there, though, that we feel that may help you understand the process by how the residents at your facility are going to be classified. There's a classification walkthrough. The grouper tool is in there, and then the NTA comorbidity mapping. They've actually put all the comorbidities in there and kind of mapped them over. It's a large Excel file, so it takes a few minutes to download it. There's also some fact sheets in there, that those fact sheets just give brief information about specific topics, and they kind of go through every topic that goes hand in hand with PDPM. All right, Liz.
Okay. Yeah, no, thanks. Great information, Kathy. I hope that we have given you some good information and some questions maybe to start asking within your facility and processes to start looking at. Again, the I0020B is going to have a direct impact on CMI for PT-OT speech. Comorbidities are going to have a big impact, particularly on speech and the non-therapy ancillary. So making sure that we have processes to capture that admission diagnosis and the comorbidities are going to be crucial moving forward October 1st. And thanks so much for joining us. We will be having another session next month.